Could all the speakers from the session please come and stand here so they can answer questions for 10 minutes, please? That was an amazing conference, I have to say. Francis and I were there as well. It was very interesting. Could we have the roving microphones, please? So I'd like to ask, is it Professor from Russia? Where is he? Where's your colleague from Moscow? Nicholas? Ah. Oh, okay, had a flight. Can I ask you, maybe you can answer my question. He mentioned that he was doing allergy testing on many of the patients, and that was something I saw Francis also looking interested in that, and he said that the patients had a lot of allergy. I've never patch tested an EB patient. I've not heard about patients having a high degree of allergy before. Where's the roving microphone? So could we have some answers, please, from you? And then perhaps comments from the other clinicians about the same issue, please.
Thank you for your question. All other patients have allergy from food. Applicant.
Would you?
Sorry, just a moment.
I can't believe how good she is answering in English.
Our patients have food allergen and have celiakia, gluten allergy, and they react to the wet condition and injection. And have allergy to inject.
No, not how you're doing it. It's why are you doing it, and are you finding not patch testing? It's blood testing.
Yes, blood
Okay.
test. Only blood testing.
Okay, Francis, could you comment a little bit about this?
It's an interesting point because we have looked for the intestine. We make endoscopy and we have made biopsy, and our patient have a chronic condition that decrease the levels of villus in the intestine, so they have atrophy, as most of our patients who also have decreased nutrition. So we have a different intestine in our experience, and when we usually, not often, made an endoscopy. And we haven't looked for allergic condition. We always saw the patient, and we haven't seen in allergic conditions, soft in one case of Kindler disease. That in Kindler disease there are description of allergy, but I don't know if you are talking about all type of EB or you are putting attention in one point in Kindler. I don't know.
Thank you for your question. Yes, our patients all types of EB included Kindler syndrome.
Even simplex?
Yes, and EB patients with simplex EB type.
And what kind of allergy you did detect?
Food allergy, milk, meat, and apple. And apples.
As well as wet condition, wet, and there are a lot of humidity.
So the poor patients were trying to feed them up, and now they can't eat certain foods because now they're allergic to them.
You want to comment?
Yes, we have some patients with allergies, but not more than in other populations. So just this is what we realized. But as far as I know, there is a group in Italy. They are trying to figure out the thing with the gluten and EB. And maybe there is something behind it. So I also have one patient whose mother had a gluten allergy, and so she was fed gluten-free all the time, and she had she has a severe dystrophic EB, and she's one of the tallest EB patients I've ever seen. So maybe there is something in it, and we are thinking about it, but we didn't do special allergy testing, except
Diana?
when we had the suspicion that there might be something going on.
Yeah. Diana, any experience with this?
I've been involved with the care with one child who had multiple food allergies and also eosinophilic esophagitis, which is a...
But the child had EB as well?
The child had recessive dystrophic
Really?
EB. I guess if you think back to general principles of how allergic sensitization occurs, you could say
A broken
that
membrane in the
through
gut.
broken skin barrier, much like we see in eczema patients, you could postulate that patients with EB are perhaps at high risk of sensitization. And the question then is whether it's a clinical allergy or whether it's a blood test sensitization is an interesting one, I think.
Professor Z?
For my opinion, I think this kind of patient, we need evidence base, but sometimes I think the best evidence is the food. Is some food you really if the symptoms is not very severe, just believe yourself, not believe the test result. I think.
Okay. Does anybody else? Yes. Could we have the roving? Is there another roving microphone or just the one? Yeah. Can you pop it to this lady here, please?
I think it's really interesting that you are taking these allergy tests. I'm an EB patient from Norway, and it's like you're describing my family, because we are a big family of simplex, and most of them have celiac disease or any allergies. So I would just say thank you.
Something new that hasn't come up before in any of the EB meetings I've been to. Francis?
One comment is we often check blood tests very, very often because anemia is one of the very big issue. And we don't really see much patient with eosinophilia. So that is an our experience. But maybe we have to think also in that and come back to the gluten allergy. One of the key issues to have the diagnostic is biopsy of the intestine. So we will see atrophy, and it will be the same in every severe patient with malnutrition. So will be a complex issue to understand very well what happened. But it's an interesting point that we have to look.
Can I ask about the bone marrow transplant program? When I was in a Montagna meeting in America, Jacob Tolar said that they had 6 patients with graft versus host disease from bone marrow transplantation with EB, and 5 out of the 6 had died from that. And you mentioned something in your talk about graft versus host disease in your patient. Have you transplanted any other patients so far, or is this the only one?
This is the first one. In China, another one is the second is already done about 1 year. Now we're prepared for the third one in our hospital. And the first one in hospital, I think she's lucky. She really got the GVHD, but not very severely. And after about 1.5 years, we just delete the drugs to 2 cans of anti the GVHD.
So she's not on prednisone anymore to treat the GVHD?
Not prednisone.
Is she on another immunosuppressant drug?
Yeah.
Which one?
Which one?
Tacrolimus?
Cyclosporin, right?
Cyclosporin.
A. Yeah, cyclosporin A. For last of 1.5 year, and but she got a very severe infection and CVS, but we
Did you measure her disease extent score before the transplant, and what is it now? Did you do EB-DASI or Birmingham EB score or anything objective before the transplant, and then now to be able to compare the improvement?
Oh, yeah, we do some work about the EB score, and I think just 70, maybe 70% of the layers.
70% decrease in the active wounds?
Yes.
Okay. Do you have any comments, Francis, why you have chosen at the moment not to pursue bone marrow transplantation in Chile, given that you could be doing that if you wanted to?
I think you have to clearly understand that bone marrow transplantation, even in the more experienced center in the United States, have more or less 20% of mortality only by the procedure. So it's a risk procedure. So we decide in Chile only to go to a bone marrow transplantation in the case where we had a severe the severe junctional type called Hurlitz type. So we had a family that have a first child who died very early because have a LAMB3 mutation, and this family, the mother get pregnant again, and we make the genetic test and we discovered that it was also the same mutation in LAMB3, so it was a lethal form of junctional EB. So the only way to offer some option to this family was to make the bone marrow transplantation. So we make a protocol. Jacob Toller, that was in the movie, we make every morning at 6 a.m. a teleconference with Jacob, and he was a wonderful help for us. And we make the bone marrow transplantation. In the first time that Jacob make a transplantation or monitorize a transplantation without wounds, because this little girl come with only one bullous in one hand, but we know that will be very severe, and we make the transplantation and we look for LAMB3 in the skin, and they appear, the LAMB3. But then they appear also the big issue that we were talking yesterday, that after 3 or 4 weeks, they appear, the wounds in the junctional EB. And it was very severe, and it was very difficult to maintain an equilibrium between immunotherapy to get the bone marrow and don't have rejection, and infections. And so this girl have a severe infection by fungus, and also develop an infection severe by Staphylococcus aureus, and she died at 6 months. So it's now very, very clear, and in the States, the LAMB3, all the LAMB3 bone marrow transplantation died, so we don't have to go there this way.
How about in Austria, EB, what do you feel about the transplantation program?
We also decided not to do it now, because we think that there are other options to care for the children, especially for, as you mentioned, junctional EB. And my personal experience is just with recently, in last year, 2 patients with junctional EB, 2 young babies, and one family decided to try, and the others decided not to try. They got the procedure in Germany.
Or in Germany?
No, they got it in Germany. And, well, one baby went to the age of 12 months, I think, with staying 10 months of these 12 months in the hospital. And the other one was 13 months and staying just 2 weeks in the hospital. And this was the child without bone marrow transplantation. And for me, at the moment, I think for these children, I can't see any positive outcomes here. And as long as the protocols will not have changed, we will not do it. And we also don't do it for recessive dystrophic EB, because at the moment, I think 20% lethality is too much. So they have a good chance for a good life with other possibilities. But on the other hand, I think we have to think about these things. We have to try somehow. We have to go these ways. But if I'm honest, I'm happy that I'm not the one who has to make to do these decisions.
In Vietnam, I had experience where there's a bone marrow transplant unit in the Children's Hospital in Hanoi, and they transplanted 3 children with recessive dystrophic EB, but they all passed away. And I believe they've stopped doing it there as well. So, does anybody have specific questions? Good. Over here. Would you like to stand up? Mr. De Graaf, May's husband.
Is there any possibility of gene editing the person's own bone marrow and transplanting it back?
Who's going to answer that question? Maybe Francis?
There are some editing that have a good result with CRISP, that is a special area that they have publication. But one of the things that come back again is bone marrow transplantation, even in the correct cells, needed to be in a complex unit. Also, if we correct the gene and to put the new bone marrow in a person, if they have some issue without immunosuppression, you get the risk of infection. So that's the way, a wound. You can imagine a burn patient that you use immunosuppression. You don't think so. But in EB, if we needed to immunosuppression, the risk of infection is very, very high. And the risk of infection and sepsis and suddenly death is one step. So there are many ways to go. We are trying to get to the summit. We are trying to get to the Everest, and we have different ways to go there. So we have different teams trying to go by different ways, and I think Dr. De Luca, in a publication in Nature, make a tremendous amount of contribution to understand, especially the concept of holoclones. That is a very interesting concept. And I am sure we will get it better acknowledgement, and we have a light in this tunnel. And we are trying to get it to the summit, and we will try to do the best in every expedition.
Well, as it's tea break time, I'd just like to close the session by thanking all these wonderful speakers for their presentations.